here in Virginia, you know, we understand that the kinship care is critical to the health and well-being of children and families as a whole. And preserving family systems leads us down the path of child and family well-being. And in Virginia, we've made some gains over the course of the last few years, but clearly we have a ways to go. And I know today will be a very informative, very inspiring webinar. As Dr. Avula unpacks for us, the concepts related to adverse childhood experiences and the essential role that family and community connections play in ensuring the long-term health and well-being of children and their families. So without further ado, I'll turn it over to Dr. Avula. Take it away, Danny.
Thanks, Garrett. Afternoon, friends. Great to be with you all. I'm going to share my screen up here. And today we're going to really jump into this topic of adverse childhood experiences. And it's always hard because I don't know, I feel like talking to a bunch of folks who work in DSS and a lot of whom have social work experience. I imagine you've come across this at some point, but I've also recognized over the years that I've been talking about the social determinants and adverse childhood experiences that inevitably there are people in the audience who that this is new for. And so I guess I'll keep doing it until that's no longer the case. And Brenda, can you give me a thumbs up? Are my slides up? Okay, great, thanks. So I'll start here. And this, if you remember one thing from what I shared today, this is it. That significant negative experiences during childhood can actually impact brain development and the immune system. And that can really greatly increase the risk of health and social issues over the life course. Many of you know my background is as a pediatrician and a public health doc. And this learning around the adverse childhood experiences has really changed our focus in the field over the last 20 years or so. And so I want to start a little bit with the big picture around the social determinants of health. For so long, when we think about health outcomes, we think about these guys. We think about doctors, and we think about this through the lens of healthcare providers and our ability as providers to improve health. And I think the last 20 years of really understanding what drives health outcomes at the individual and population level has changed our understanding of this a bit, or more than a bit, really. I think it's helped us understand that much of what we do in healthcare, when we treat sick individuals, makes them less sick, but doesn't always make people healthy. And that has been because we start to peel the layers back and understand that the drivers of true health often are much deeper than what comes into an ER or what comes into a doctor's office. And so there was a great study back in 2010 that looked at the population level, what actually contributes to health outcomes. And what you'll see here is that healthcare, actually seeing a doctor and the quality of care that you receive, really only accounts for about 20% of your health outcomes. And that the other 80% of what drives health outcomes are things like the built environment, the air quality, or the safety of green space, your socioeconomic factors, like the level of education of your parents, or the stability of employment or stability of income, family and social support. Or health behaviors, what you eat and drink, if you engage in risky sexual behavior or not, if you use substances. So, the point is that healthcare, what we think about as healthcare providers, really only is a small part of this pie, and that much of what determines health is in these other arenas that we now know as the social determinants of health. So this has really changed our practice in public health and social services. And, if you look at this, a complicated slide, but if you look at the right side of this, you see that much of what we were doing in public health and healthcare has to do with reducing mortality and reducing disease and injury. This is the medical treatment of illness, the treatment of communicable and chronic diseases. And as we've learned more about the social determinants of health, we have really tried to go upstream, so to move left across this, where our work is more focused on things like the built environment, things like stable housing, and our understanding of how stable family and stable income actually produce better results. And so we have progressively tried to move upstream into things like living conditions, and even further into the sort of systemic and structural drivers of poor health. Institutional inequities and social inequities, things like race and class, gender or sexual identity, and understanding that all of these things underlie the lived experience that results in poor health outcomes. So let's now talk about a specific subset of the social determinants of health called adverse childhood experiences. And I start with where this really started to emerge back in the late 90s. There was a physician named Vince Folletti, who was a preventive medicine doc running a big obesity prevention clinic in Kaiser Permanente in San Diego, California. And, he had a huge clinic and it was really successful. He was seeing, people lose weight to 100, 200, 250 pounds. And it was really remarkable what was happening. But over time, one of the things that he recognized is that there was kind of this abnormally high rate of women in his obesity reduction clinic or prevention clinic that would lose 150 pounds and then they drop out of the clinical intervention, and then they would gain that weight back. And so he started to wonder why is this not working for this subset of the population? And so he started asking them to come in and actually interview with him. And what he found, really, really surprising, right? He would ask kind of these detailed questions that we as, health and human service folks kind of think about often in our own interactions with clients. But he would ask questions about their past and about their home life. And one of the questions he would ask was, how old were you when you first became sexually active? And one day, almost by accident, he misspoke and he said, what weight were you when you first became sexually active? And the woman that he was talking to paused and she thought about it. And then she blurted out about 40 pounds and began sobbing and proceeded to tell him the story of how she became sexually active when her father raped her as a young child. And as he started to interview more women and fine tune his questions based on that experience, he kept seeing this story, this pattern of childhood sexual abuse pop up. And he said to a colleague, I've been in practice for 25 years and never have I heard anybody talk about childhood sexual abuse. And now in 1 week of interviewing patients, this has come up 4 different times. And so he recruited other patients who had dropped out of the clinic and just started to see this pattern where out of 186 patients that he interviewed, 55% of them reported a history of childhood sexual abuse. So a couple of years later, he was presenting to some colleagues at the CDC his findings from these interviews. And they said, 186 patients is pretty compelling, but to really establish the evidence base, to really understand the science, we've got to do a much bigger study. And so he paired up with a guy named Rob Anda, who was an epidemiologist and physician at the CDC. And they did, with the population of patients he was seeing at Kaiser, they did a 17,000 person study where they did these really in-depth interviews of patients, asking them about their history and what was going on in their childhood, their home life, et cetera, et cetera. And this became, in the late 90s, this landmark study called the Adverse Childhood Experiences Study, because what they found was that in all of these interview responses, that there were 10 occurrences during childhood that really closely tracked to a number of concerning health and social outcomes. And specifically, what they saw were different kinds of abuse, physical, emotional, sexual, different types of neglect, physical or emotional neglect, or issues that would arise in the household, like mental health or an incarcerated relative, or intimate partner violence or substance use, or fragmentation of the family, divorce. And these 10 things kept popping up over and over and over. And as a result of this large-scale study, they found that these things, now termed adverse childhood experiences, actually contributed to really significant increases in injury, in mental health, in reproductive health outcomes, in infectious disease, chronic disease, health behaviors, and ultimately opportunities for health and well-being. And not just in small ways either. The initial data showed a 55% increase in the incidence of anxiety in people who had experienced these adverse childhood experiences, or a 67% increase in life dissatisfaction. And furthermore, not only was there kind of this one-to-one correlation of people who had experienced adverse childhood experiences, but there was also a dose-related response, that the greater number of adverse childhood experiences someone could point back to, the worse the outcomes were. So for those who had had 4 or more ACEs, you would see twice the risk of cancer and heart disease, so chronic disease outcomes in adulthood. For 5, you would see 8 times the risk of somebody becoming an alcoholic in adulthood. For 6 or more, you would see a 20-year reduction in life expectancy. And this was true in almost every category of health or social outcome. And so you look at things like alcoholism or smoking or sexually transmitted infections, teen pregnancy, suicide attempts, and all of them had this clear dose-related response, that the more adverse childhood experiences someone experienced in childhood, the higher their risk, the higher their likelihood of developing these outcomes would be. And this was not only true much later in life in adulthood, but it was also starting to show up in childhood. And so you see here just a few examples of things that popped up in pediatric health: higher likelihood to develop allergies or headaches or asthma, higher likelihood to have digestive problems, or frequent school absenteeism. And so you really start to see over the course of the last decade, the evidence base around ACEs and the incidence of ACEs and all of these different health and social outcomes. So why does this happen? This is a really helpful diagram that the CDC published, and it starts with this base of adverse childhood experiences. And remember where I started, that the incidence of these stressful occurrences during childhood actually leads and impacts brain development. It actually has physical implications. And so it disrupts brain development. And that disruption leads to social, emotional, and cognitive impairment. And impaired activity results in higher incidence of high-risk behaviors, which down the road leads to disease, disability, social problems, and early death. So this is kind of the cascade that starts with these ACEs during childhood, the disruption of brain development, and the adoption of risky behaviors. Here's a side-by-side scan of brains. So there's a PET scan of 2 brains, one in a healthy child and one in a child from an orphanage who experienced a lot of physical abuse and neglect. And what you see is in the healthy brain, you see all of these red and green areas of high levels of brain activity. And in the comparison here with the child who lived in an orphanage, you see much less red and green activity. You see much lower levels of brain activity at the same age. And so again, the experience of abuse and neglect during childhood, during those really important developmental period, actually has physical impacts on brain development. So let's talk a little bit about that. Here's a pretty simplified diagram of the brain. And what you see here, this red brain stem, what people refer to as the animal brain or the primitive brain, which is really responsible for your sensory and motor function. Survival responses like your fight or flight response really all emanate from this brain stem. And so when development of the brain stem has been impacted, that results later in life in disrupted sleep patterns, issues with coordination, and then an accentuated fight or flight response. The blue part of the brain here, the limbic brain, really is where your emotions and your personal attachment and your memory responses get developed. And so when you get disruption of this part of the brain, that leads to a lot of rejection and different behaviors like hiding and stealing, a lack of emotion, and a lot of expression of anger, fear, and self-harming. And then the green part, the prefrontal cortex, is the part of the brain that we rely on for thinking, learning, language, executive function, judgment. And when you have disruption in the development of the prefrontal cortex, you see issues with planning, remembering things, recalling things, and that often presents as self-hate and self-blame. And so you start to see that there are these real impacts of that disruption of brain development in the early years that show up throughout life. And so when we come back to these adverse childhood experiences and start to understand that these are the things that drive the disruption of brain development, and then that whole cascade I showed you earlier, we don't get here and then say, well, that sucks, we can't really do anything about that. We, as practitioners of health and human services, really need to shift our practice and figure out, how do we use this knowledge of the adverse childhood experiences to focus on prevention and resilience, right? Like, our entire approach to how we support kids and families really is rooted in prevention and the building of resilience. So what are some of the ways that this happens? And I'll kind of be brief here. One is strengthening economic supports. We've talked about the tie between poverty and increased incidence of adverse childhood experiences and poor outcomes. And so strengthening financial security is a huge part of what we do in social services to stabilize families. There's a big focus on early education, right? The whole K through pre-K movement, but even before that, really, exposing kids early to books, to reading, to nurturing. That early education is so important. And then focusing on parenting skills, because we know that the more equipped parents are to care for their children, the more we're going to prevent these adverse childhood experiences from happening. So what's the tie here? Because this is Kinship Month, and the whole reason we're here is to talk about why kinship care is important. And so I want to firmly connect the concept of kinship care to one that both promotes prevention and resilience in those who have experienced adverse childhood events, because we know that those kids who for whatever reason have to be pulled out of their biological family, their family placement has to be disrupted. If they're placed in a kinship placement, so either a relative placement or somebody who has a pre-existing relationship, so a teacher, a coach, a pastor, that outcomes are better, that kinship placements really can help with improved emotional support, financial stability, helping to manage relationships with the patients and provide a different kind of emotional support. And so we'll hear much more about this from our panel. I'm super excited about the panel that you guys will get to hear from. I'm sure Curtis is really incredible, but I have a strong bias here. Arjune, our daughter, is actually going to share a little bit of her story too, which is thrilling for me. And so much of our life over the last 5 or 6 years has been living this and understanding the impact of kinship care. And so I'm really excited for you all to hear from her. And so I'll end with this as we think about the gift that kin placements offers. Is really a relational one. And this is from Dr. Bruce Perry. He's a physician who is at Northwestern University, but really one of the leaders in the trauma and resilience field. And this quote is this: "The more healthy relationships a child has, the more likely he will be to recover from trauma and to thrive. Relationships are the agent of change, and the most powerful therapy is human love." And so that's why we're here. We're here to talk about the importance of kin placements, the value that those kin placements provide in relational connection, both to their primary family and to their foster or adoptive family, and to experience this most powerful therapy of human love. Garrett, back to you.
Thanks, Danny. Thanks so much. Hey, and before we begin with Curtis and Arjane, I just want to follow up on some of what was shared related to kinship care, and to give you an idea of, in the context of children entering foster care in Virginia, we can see that from July 2021 through June 2022, 1,725 children entered foster care in our state. 158 of those were first place with relatives upon entry into foster care. So I think that really reflects the work we have to do to invest in our kin first culture, because we know from our own data, 96% of the time when children are placed with relatives, they will exit to permanency, either through return home, custody transfer to the relative, or adoption by the relative. We know that they spend on average 4 fewer months in foster care, and we know that their placement stability is significantly improved when we invest in keeping children connected to their family systems, their natural supports, the people, the institutions that understand how to support them and meet their needs. And what our children need more than treatment programs and service providers are connections with adults. And then our role as child welfare professionals are bringing families together and empowering them to work together to support one another, to strengthen that family system as a whole, and to chart a different course for our children. In Virginia, we also rank 49th nationally related to children aging out of foster care, despite the fact that we take fewer kids in foster care than almost every state in our country. So again, our investment in kinship care leads us down a separate path. So I could go on and on about the benefits of kinship care, and I know many of you have heard me go on and on for a number of years now. But we're lucky today to have Arjane Avula with us and Curtis Winfrey. Arjane is a third year at UVA, and as the commissioner mentioned, she has a special relationship with his family. Curtis Winfrey is an individual with lived experience who hails from Charlottesville, Virginia. He currently works and lives in Richmond, Virginia. Both are amazing individuals, amazing people, and we're so lucky to have them here with us today. So, hello, Arjane. Hello, Curtis.
Hi.
Hello. Thanks.
Hey, so we want to have a relatively informal discussion today. I want to start off by asking you to tell us about your family. And Arjane, why don't we start with you?
Okay, so as you know, the commissioner is my dad, but my biological family, I'm the oldest of 15 kids. 11 of them are my biological siblings. I grew up with my mom, my grandma, a little bit of my dad, my aunt, like just rotated throughout family members. I met the Avula family in 2014. Randomly, I just literally walked up to their house and was like, hey, like I see you've been like remodeling this house. I really like it. And then we just became really close. I joined their family like officially in 2019. Yeah, that's a little bit about my family.
Okay, thank you. Curtis.
Yeah, so I have two siblings. I have a younger brother, Sean Winfrey. I have an older brother, Marcus Winfrey. I'm from Charlottesville, Virginia. I spent most of my early childhood with my mom and dad up until around 10 or 11. And then from 11 till I aged out of care at 21, I was in residential facilities and different group homes throughout my childhood experience.
And Curtis, were you in foster care?
Well, I guess you can say it was foster care. I mean, a group home and a residential. I wasn't like a foster family or anything, but I was like, I guess you can say a ward of the state at the time, yes.
Right, right. So, based on your experience, Curtis, spending certainly the early part of your life, with your family, and then, entering foster care and being separated from your family for a significant part of your, your adolescence and even, early adulthood. When you think about that, why do you feel like family is important?
Well, I feel like family is important because it gives you a natural sense of security. I went from, having a brother, my mom, my dad all together in one household to the next day it was all gone and I'm living with, strangers, different folks. And also not having that connection while I'm going through my journey, it made it hard for me not being able to call my mom, not being able to call my dad, not being able to have my brother. I mean, I had my whole life turned upside down. I went from getting love and nurturance to not giving love and nurturance. So I feel like family is important just for the survival of the child. It's really hard getting through those obstacles, being a child, not having anyone that care about you or guide you. I felt alone at times, and I wouldn't. It's not a good feeling for children to feel abandoned. I felt abandoned by my own parents because I'm like, I don't want to go, I want to stay. But it's like if my parents couldn't do anything, but I felt like they abandoned me, but it was out of their hands. But just having a family connection, would have kept me grounded, would have made my journey a little bit easier than it was.
Okay, thanks. And Arjane, same question, same idea to you. Why is family important? Obviously, your experience was different than Curtis,
Yeah.
but
I think for me, like family has just served as like kind of like what Curtis said, like it's kind of like it's been like my rock. Like no matter like what's happening, like the changes I'm going through, I'm living at this house. I'm like my family, like it's always just like it's something that's consistent, like something that like I can always rely on. Like even like I'm a college student and like I'm going home this weekend to like visit my family, like and like they're there. Like I don't know. I think especially with people in me and Curtis' background, like it's good to have something that like stays the same, that's grounded. Like no matter like the things that's like going around us, that's constantly changing. So
right, that unconditional support that is irreplaceable.
yeah.
And Arjane, you mentioned sort of now that you're a college student, the role your family still plays in your life. Curtis, what about you? How does your family support you today? How do those relationships play out, given your experience?
So it's a great question. Honestly, they don't. I mean, I don't have a connection with my family. Like they don't know me. Like when I go, we have like family get-togethers. I'm like like a family friend. And these are like my and cousins. It's not that they don't love me or care about me, but they just don't know me. They knew me up until 8, and then they met me again at 21 when I was able to, have my own connection with my family. But from 10 to 21, they were absent. And my brother, thankfully to Garrett and Darian Hall, I was able to maintain a connection with my younger brother throughout it all. Me and his connection is strong. We're stronger than ever. We kind of spend more time now embracing the time that we do have versus the years that we didn't have. But yeah, I wish I had a stronger connection with my family and my extended family, but for now, I've just embraced my wife's family. You know, I have my grandmother on my mom, my cousins and aunts on my wife's side. So, you know, for that, you know, family, they've been a support for once to me throughout my life.
Sure. Hey, and Curtis, just sort of a follow-up question. You know, thinking about your experience, you know, as you reflect on being separated from your family, are you aware of missed opportunities that that child welfare professionals or folks involved in making decisions about your care really, you know, opportunities that weren't capitalized on to preserve those family connections and prioritize them?
Yeah, I think there was a misconception that based on like my records that, you know, I was making good progress. I was doing good. I was doing a good job. I was doing a good job. I was going to school, and they had the fear that, hey, if we take him from this progress that he's doing and give him back to his family, he's going to regress. All that good work will be wasted. But in all actuality, you know, I was doing the good work, thinking that I was going to go home to my family. It's like I can't be getting in trouble at school, not doing my homework, and out in the community, you know, being a menace. They'll say, "Hey, Curtis needs these services." But on the flip side, Curtis is doing good. This is what, you know, he's doing a good thing. This is why he's here. We don't need to sabotage his progress. And in all actuality, it hindered my progress because my whole objective in my mind is if I do right, I'll get to go back to my family. But that wasn't the case. And it hindered me with my development with my family. In terms of social development, I don't have the social connection with my relatives, man. And it's a big void in me right now, even till today, because I love my uncles and my cousins and my aunts and my grandmother, but it's just they don't have that same love for me just because we didn't have that time to grow together and bond.
Hey, and Arjane, you spoke about, you know, the role of the Avulas in your life. You know, being a part of their family, have you been allowed to still remain connected to your biological family? And what's that been like for you?
Yeah, I have. I feel like since like even when I was thinking over like the ACE score, like I think like so much of this is like generational stuff, like the same things I went through, like my biological family went through. And I think since like I was like removed from that and like placed like somewhere healthy, like they don't understand like the concept of that. So like it's a lot of friction in my relationships with my biological family. Like it's there, but like they don't get it. I mean, how will they get it? So like even me being at college, like they think it's bonkers. They're like, wait, what are you like, why are you at school? Like, why aren't you just like why are you doing that? Like, why are you wasting your time doing that? So I do have relationships with them, but they aren't the best relationships.
Sure. Complicated.
Yeah.
So, you know, thinking back to sort of your connection, you know, with your family, particularly in the early part of your life, Curtis, do you remember, you know, the family traditions or things that you all did together come to mind that you reflect on, you know, bring you some happiness, but also, you know, you realize you missed out on them?
Yeah, well, the biggest one was like Thanksgiving and Christmas, the holidays at grandma's house. I mean, you have your birthdays, you have Christmas, but anything that was going down at grandma's house was like almighty. And I went from having these holidays every year to one year, TJ's no longer at the family dinner, you know, and being where the location that I was, you know, not being able to go home on home passes and seeing other kids going home for the holidays, and I'm stuck at the group home, and they take me to McDonald's because they feel sorry for me. I mean, I just can't explain like how much it meant to me to be there and how much it hurt me not to be there. I mean, family is everything. I mean, I can't stress it enough. Just that from that the maternal bond. Um, yeah, man, just the family vacations that I missed, the family time. It's yeah, that's it.
Sure. Um, Hey, Arjane, how have your family relationships changed or developed over time? With your biological family and the Abuelas.
I think with my biological family, specifically like my mom's side of the family, my siblings, I feel like because of the Abuelas, my relationships, both with my biological mom and my biological siblings, have shifted so much just because I like know so much about like just so many different resources and opportunities. So like I feel like I'm on this like trajectory where like I'm being shaped by the Abuelas, I'm being taken care of by the Abuelas, like I'm being shown like how to love, how to care for someone well, and then I'm doing the same thing for my family. So like, yeah, it's kind of like copy and paste. Like this is this thing that I'm being taught as an adult, and like I'm caring for my siblings the way I was supposed to be cared for as a child, which have had lots of great income like outcomes so far. I mean, it's just the beginning, but seems great.
Wow, that's a great way to put that. Yeah, it's like the love, the care you experience from the Abuelas sort of really set an example for how you want your relationships with your family, your biological family to look. And then even moving forward in your life, relationships with people that are important to you, that unconditional support.
Yeah.
Yeah, that's fantastic. What about you, Curtis? How have your relationships sort of developed, or what do your relationships look like with your brothers, with your family, as you've gotten older?
So similar to Arjuna, as I've gotten older, there's more information out there available. And one thing for me in my chart, I always refer back to my charts to see what was said. And one of the physicians said that one of my biggest Achilles heel was like my need for family. Like I was always wondering, thinking about my family versus focusing on my treatment. And because I'm older now and I don't have that connection, I've kind of like let it go in terms of wanting to have that connection. Like I don't fight for it as much. If it happens, but I do want it. So I've been able to just focus on me and my personal development and being able to help others, in my community. Just some of my experiences, I'm able to identify in the community center. I can identify families who are dealing with things, and I'm able to address them and offer services based on the experiences that I've been through, interacting with different folks such as yourself, Garrett. And it's just been really impactful for me to grow. I've grown a lot. And just like I said, having that information, you guys doing this forum, bringing uh, so much awareness to this ongoing issue is just powerful. And I'm so glad and thankful to be a part of it.
Yeah, and I feel like what you both shared really highlights sort of the role that family play in resilience and the ability to heal from trauma that you've experienced. And Arjane, like the example that you gave of sort of transferring what you've experienced with the Abuelas to your family, and then Curtis, your ability to reflect on what you missed, and working on those relationships to reconnect and start to heal. We can really see the resilience playing out there. Hey, I know, Curtis, you had mentioned, being aware of ACEs and sort of, the concept of adverse childhood experiences. You had some thoughts you want to share. Brenda, I don't know, could we maybe put up the sort of the document that Curtis wants to refer to? All right. So Curtis, being aware of ACEs, I'll turn it over to you to share kind of your thoughts related to adverse childhood experiences and what you've heard.
Yeah, so Miss Brenda has sent this form over to me, and it has a list of 10 questions. I don't know if you can scroll down and show all of the questions. But initially, I took the score and I said, hey, I applied it to my home life with my mom and my dad. And then I said, well, hey, let me apply this to my time away from them, like in actual care in group homes and residential facilities. And I actually had a higher score being away from my family than I did being at home with them in terms of these adverse childhood experiences. 9 out of 10 of these while in care. And Dr. Avula, he spoke on it, and I'm just shocked that, I was able to pull through and come out on the other side, given all of these adverse experiences I was exposed to while in care. Like I said, this was almost double my home life. And I just can't stress it enough, the importance of being with family and loved ones. Like, that's the most important thing, is keeping kids with folks who want to care about them. Because, based on this sheet, I'm not supposed to be here. I'm not supposed to be here, but I am. And same to Miss Arjane, we both have our adverse experiences that we went through, but for us to be on the other side and talking and bringing awareness to it is just a testament to both of us and our character and our strength.
Oh, 100%.
And so just to piggyback off Curtis, when I look at this list and think about I said yes to every single one of these questions, but you see me now, I'm talking on this panel, but this isn't it. I didn't go through these things and now I'm on the other side and everything is great. It's still today, day-to-day work to work against these things, to work against the statistics, to not be in the 55%. It's just, it's not, oh, you go through those things, you live with a good family and it's over. It's it might be a lifelong process. And I think it's easy to look at this and even Curtis said we're on the other side, but it's not just that we're on the other side. You have to think about which side we're on first and what work we have to do every single day to stay on this side. It's not it's not
Okay.
Amen. Amen.
Hey, so anything that you'd like to share before we wrap up with our audience today, related to your experiences, your experience with your family, your experience without your family. What do you think?
Well, I feel like there is some good that came from me in my journey. Foster care isn't all bad. There are some great people in the field. I feel like the more that the workers who are in the field are educated, the better they'll be equipped to deal with children and their different circumstances. Each family is going to be different. What may work well for one family is not going to work for every family. And I feel like if we, handle each case by case specifically instead of as a whole, I feel like we'll better be able to help each family's individual needs. But yeah, there is some good from this. I am thankful for my journey. Although it wasn't the best journey, I'm thankful there's a journey that I had.
Yeah, for me, I'm a very oh yeah, statistics doesn't mean anything kind of girl. I just question everything. But I do think because of the history and the science behind it and just my lived experiences that family is important. I have 3 brothers that's right up under me, and one of them are in penitentiary. Another one is just wilding out in the street. And then I have another brother that's still in high school. And the things that separate me and my brother that's in school and my other 2 brothers is that family. My other brother went and joined a family. I joined a family. You think we all grew up together. We had the same mom, same childhood experience, but our outcomes of our lives are totally different because of the one thing that I think some people overlook. People think oh, you're too old, or that's not true. I joined the Avula family as a 19-year-old adult. I didn't grow up with them. I mean I knew them, but and it's not too late. People think, oh, they're already late into their teens. It's not too late. And family is important and can change people's life outcomes, no matter how old you are. That's what I got.
Well, thank you. That is so powerful, so amazing. And I don't know if I'm assuming you can see the chat, but if you haven't seen it, just lots of gratitude lots of acknowledgement of about how powerful your words are. And you know, we can't thank you enough for taking the time to talk with us today. And quite frankly, as a child welfare system, you know, the voice of, you know, the children and the families with lived experience, you know, are something that we really need to spend time elevating and incorporating into our development of policy, practice, every aspect of all that we do, every opportunity we get. And you know, as the field, we'll see in the coming years, you know, the rest of the year and the coming years, you know, VDSS is certainly going to be heavily invested in the voice of those with lived experience, and letting that drive our service delivery. So thank you both so much. I really appreciate your time and sharing your you know, your stories with us. Next up, I want to turn it over to Lori Crawford. Lori is the Director of Trauma and Resilience Policy with the Virginia Department of Social Services. And her office is relatively new, and will really have a critical role in shaping our policies and practice that ensure that we're trauma focused in order to promote resilience within the families and the communities that we serve. So Lori, I'll turn it over to you.
Thank you so much. And I really don't know how to follow that. Just as everybody was saying in the chat, and as Garrett so eloquently put, really just thank you so much for joining us and presenting to everyone. And I can only echo what's been said by everyone else. So it really means a lot to kind of have that voice of lived experience to guide this work. As Garrett said, my name's Lori Crawford, and I am Director of the Office of Trauma and Resilience Policy, which is a new office, a new division here at the Virginia Department of Social Services. I'm going to share my screen now. Okay, and okay, great. Let me get this minimized so I'm not looking at myself. So the Office of Trauma and Resilience Policy, just want to kind of give you a little kind of big overview. We could kind of talk about this for days, and I'm going to really focus this so that hopefully it fits in with the context of this conversation. The office was established for the Department of Social Services to make an official ongoing commitment to become trauma-informed and healing-centered. So we're kind of doing three big buckets, you know, in terms of our purpose. The first is to really look at the culture of DSS. So infusing and sustaining trauma-informed and healing-centered knowledge and skills into our culture, policies, and practices. The second is to foster collaboration with our other state stakeholders to better align and coordinate our efforts, because we know that our agencies, our systems are all a lot of times doing similar work, but we're not necessarily coordinating as well as we could, and that impacts how we serve the children, youth, and families that we do serve. So try to better coordinate those and connect those efforts. And then finally, engaging with local partners and communities to promote resilience and healing in children and families. And I put this in italics because I feel like that this is kind of where I'm going to focus the next few minutes that I have with you all today. I do want to just point out, I really appreciate the conversation around the ACEs, and I really appreciate it around resilience. One of the things as we were coming up with like what we wanted this office to focus on and what we wanted to name it and the work we wanted to do was that for a long time, we really talked about trauma, and that's great. We need to know the impact of trauma on brain development and how, you know, the impact on health outcomes. But we're now learning over the past few years that it's at any time you talk about trauma, you've got to talk about resilience, you know, because they should go hand in hand. And there are things that we can do to promote healing and resilience, whether it's in the children, youth, and families we serve, our workforce, our peers. There are lots of ways that we can go about doing that work. So just to give you kind of a little context for the focus part around supporting children, supporting those who serve children, youth, and families. This Office of Trauma and Resilience Policy grew out of a project, which was a 6-year grant-funded project called Virginia Heals, which was helping everyone access linked systems. And in that project, over the course of 6 years, we developed what we call the trauma-informed model of service delivery, which has kind of different components. You'll see the different sides of the wheel. Part or for things that agencies and organizations need to or should be doing at their level to support being trauma-informed and healing-centered. And the other piece is what should direct service providers, those who serve children, youth, and families across systems, what are some things that we should be doing to be more trauma-informed about how we work with children, youth, and families. So for each of these components, and right when I wrap up, I'll put the links in chat for you. But for each of these components, there is what we call a toolkit item for supporting how you implement that at an individual level or at an agency level. And there are also e-learning courses and all of this. So what I'm going to share with you, one common thread, well, a couple of common threads through all of the Virginia Heals work is engaging youth and families, and specifically making sure that we don't kind of create that big bucket of family engagement and assume that we are engaging youth when we may only be engaging parents or caregivers, so really making sure we're distinctly meeting both of those things. And the second is really relationships and how we support youth and families and identifying supportive relationships that promote healing. And so those are threads, and I'm just going to point out, I'm going to share a couple of the toolkit items with you, would encourage you to go and look at them further, but just to kind of see where these common threads are throughout the materials. So as part of the Virginia Heals grant, we developed a trauma screening tool for children and youth. And it is called the Screening for Experiences and Strengths. And the most unique part about this screening tool is that it does include strengths. We heard from folks that they said everybody, all these tools that we have, number one, are really focused on one specific kind of trauma. And so we've got to use a bunch of different questionnaires to get at what we need. Secondly, was that they're really focused on the incidents or what has occurred, what are the traumatic experiences, without necessarily recognizing that there are protective factors or strengths in most, if not all, of the children, youth, and families we serve. So as a component of our screening tool, which I'm just sharing one here, we do have a section on protective factors. So it's the final section of the screening tool that really looks at identifying where children and youth find support, whether it's through their parents or caregivers, their extended family, aunts or uncles, grandparents, whether it is through their friends or their friends' parents, through their faith community, etc. And so when we train on this, we really identified this as a key part of the screening tool to use a strength-based approach and to guide what next steps and referrals will be when you've identified that trauma has occurred, really focusing on those relationships and trying to prevent that engagement and further engagement with systems, and systems meaning making that referral so they're going to be, in juvenile justice or behavioral health if they don't necessarily need that level of care and support. Another toolkit item is our community resource mapping facilitation guide. And the really unique part about this is kind of a playbook for communities to use to identify resources that are available to children, youth, and families. This, I pointed out or highlighted step 6 of this, because what is really most unique about this process is that we're promoting identifying underutilized or non-traditional resources. Again, trying to look at making referrals to things that may not even be considered services. in the traditional sense. So how do you identify what resources are available in the community that basically support peer relationships and families and mentoring programs and so forth that build on those protective factors without necessarily being that go-to that, call the community services board and get into counseling when you may not necessarily need that level of support. So we find that when we do these mapping events that the people who are involved and engaged often have been working in the community for 20, 30 years. And they get to this step in the process where we call it digging deep and really identifying those non-traditional resources. And they discover that there are a lot of resources available in their community that they weren't even aware of because they weren't really using that lens in terms of building on those support systems. Then we have what is critical to the trauma-informed model of service delivery, which is our referral and response protocol. And this particular element, which is establishing rapport, really focuses on identifying who that child or youth considers to be their family and using an expanded definition of family so that we are not necessarily saying they have to be, the parents are, biological parents or whatever it may be, that we really use that extended, version, whether it's grandparents, aunts, uncles, cousins, so on and so forth, to again, identify those non-traditional sources of support and to maintain those relationships. And then we have our, of course, family engagement guide that we are pretty proud of, but a lot of the family engagement guide also focuses on those, looking at extended family and really asking those questions as to what they feel that their needs are, how they can be served, and letting them be the decision makers in the process of referrals and next steps. So I think I originally was given 10 minutes and I went a little early, but I think I might have been on time. I'm going to open this to questions. As I said, this is a very brief overview, but what I'm hoping is that you all will take the time as I put this link into chat, as I know folks are going to wrap, that you'll take the time to go through this website and to look at these resources, consider taking the e-learning courses and sharing them, and also follow up with me on anything that you, any additional questions or support that you might have.
By the way, Lori, I did post your links into the chat.
Thank you so much. Much appreciated.
All right, if there aren't any questions for Lori, we're at the point now to where we can wrap up. Again, I want to thank Arjane, Curtis, the commissioner, and Lori for all taking the time to be with us today. And I hope that hearing the voice of Curtis and Arjane really sets the stage for, as we leave today, thinking about how we can all become change agents in our child welfare system, in the organizations we work with, in the communities we serve, to really chart the course for Virginia transitioning to a kin-first approach in everything we do. Particularly in the child welfare system. We know that without a doubt, our own data shows us that placing children who enter foster care with foster parents in residential facilities leads to poorer outcomes when compared to those children who are placed with relatives when they enter care. It's worth it for us to spend time learning about families. It's worth it for us to approach our work from the perspective of families are the experts, and we have a real opportunity to empower them to come together to support one another. So it's been a really powerful webinar, an amazing day. And again, I thank you so much for joining us. If if I can answer any questions or make any connections with either Curtis or Arjane to pass any information on, please let me know. And thanks again for joining us. I hope everybody has a great day.